So Walking Forward is funded by the National Cancer Institute, and I break it down into timelines as far as periods of cycles of funding. So I'm going to go through those cycles, what our program is all about. We're now on our fourth R01. We've had a lot of foundational grants, but the two most common questions I get asked are, one, how did you start it, and two, why are you doing this? Because a lot of physicians in Rapid City, they're like kind of perplexed. We're doing all this work in this particular space. So I'll go through the rationale for designing the program, discuss the importance of patient navigation. I'm going to acknowledge three of my staff here today. Romaine Tobacco, raise your hand. Where's Romaine going? There she is. She's out of Pine Ridge, one of our researchers and navigators in Pine Ridge. Doris Steve-O, she's also from Pine Ridge, raise your hand. And Michelle Sargent's back there. Any questions I can't answer, these three will answer for me, all right? But they're really the core of our program. All right, I can just do this without slides.
Oh, just tell me if you need help. Next slide.
We'll go to the next one, because I tend to go quick on slides.
Okay.
All right, so I should have changed this to the blue slide. So if you go by the Cancer Center, right now we're in a huge construction project. You can't even see where the Cancer Center used to be, but they're expanding it right now. But when I moved here in 1999, next slide, I have no control how, no physicians have any control how patients present. I mean, probably one of the most important prognostic signs is how do you present? And so it wasn't long when I was there, next slide, where it became very evident that 15 to 20% of the cancer patients are American Indians. And it was just firsthand experience, like, gosh, for all the screen detectable cancers that we're seeing, it really seems like the Native Americans are really presenting with more advanced stages of cancer. We know that's true from all the data that's been published, but we did look at our own tumor registry, and try to read all this. But for all the screen detectable cancers compared to non-natives, there was definitely a big disparity. They were presenting with stages 3 and 4 as opposed to stage 1 and 2. Again, I wish I had used my other slides. Data that you're all aware of, but the Northern Plains American Indians have some of the highest cancer death rates in the U.S., especially for lung cancer. The importance of that we'll get into in a little bit. But that's really kind of the overarching disparity. Next slide. So what are the factors that potentially contribute to this? We published this, and there's a lot of publications on it. I think a lot of the cancer disparity talks you'll hear about are, okay, this is the problem. Our emphasis has been on, okay, how do we potentially face the problem? So there are high rates of high-risk health behaviors and comorbidities, social stressors. Over time, there has been low screening rates that may be related to resources, how well IHS is funded, the trust, the geographic remoteness, health literacy. I think a lot of these areas are improving. You put all those factors together, and it's probably three of the most important reasons that Native Americans present with more advanced stages of cancer compared to non-natives. Some data out of Pine Ridge. This is a young population. Unfortunately, a lot of folks live below poverty, and they have some of the lowest life expectancy in the U.S. It's not just from cancer, but it's from other causes. Next slide. So literally and figuratively hit the road in 1999, 2000, came here with implementing a lot of new programs in oncology and really wanted to get an idea of what's going down. This is one of the roads to Pine Ridge. People outside of this area really don't understand how geographically remote we are and what the distance are that patients have to travel. So spend a lot of time with tribal councils, health boards. Next slide. This is an editorial I wrote. I'm glad to share all this. It really gets into how we did this and why we did it. Next slide. So the stars kind of all aligned in 2001, where the National Cancer Institute announced these CDRP programs. And it stands for Cancer Disparity Research Partnership. I could just yell too, but I'll keep talking into this. And so the idea was that they wanted to establish research programs. Interestingly, based on radiation oncology, you would think this would come out of primary care clinics because they felt they would be more technologically enriched. But to be a candidate for putting in for these grants, this was a competitive R01 mechanism. Obviously, you need a research plan, you need access to a population that suffered cancer disparities, and they really wanted to build infrastructure in community cancer centers. Because what tends to happen, not to pick on the academic people, but they get all the money trickles down to the little guys. They also get all the indirect money. So as a result, there's not a lot of money that goes into community cancer centers. Next slide. So we put in for, remember, I'm a radiation oncologist and not social sciences, don't have an acronym, but I kind of figured this out over time. So part of this was behavioral research, and we partnered with Linda Burhan-Stipanov, who's a well-known native researcher, Judith Cower, medical oncologist at the Mayo Clinic. We designed a big component was behavioral research to assess barriers to earlier cancer detection, culturally appropriate community navigation, comprehensive community education, comprehensive patient navigation. In fact, when we received the grant, so we're going to get another couple $100,000 to do patient navigation. I said, well, that's great, but I'm not sure what that means. But we have partners that help me out with this. Recruitment to clinical trials, especially trials that are relevant to the population. And because patients that come to Rapid City from Rosebud, Pine Ridge, and Cheyenne River, at that time, Cheyenne River either went to Bismarck, Sioux Falls, or Rapid City. There was no cancer center in Peter, but there is now. But the average distance was at least 150 miles. So for common cancers like prostate cancer, breast cancer, and you'll see how this unfolds, we designed phase 2 clinical trials to shorten the treatment duration, with the hypothesis that these interventions could potentially lead to patients presenting with earlier stages of cancer. At any point you have questions, just raise your hand. Next slide. Talk to a little bit about the distance that patients travel. Back in 1999, it was kind of a nice sleepy cancer center here. I would say a lot of it was palliative care. They were doing a lot of innovative things. So we brought a lot of comprehensive programs out here. Brachytherapy, IMRT, these are words you may not be aware of, but I'll get into that in a little bit. So the NCI wanted us to, look at some of these barriers, if we were funded, which we were, enroll patients on clinical trials, our own phase 2 clinical trials, and cooperative group trials. That was a big metric for us. Next slide. So 2002, we ended up getting the grant. It was me, myself, and one assistant. Really no one working with me on this other than my collaborators. The way this was set up is that you have a partner with the NCI designated cancer center, so it made sense to partner with the University of Wisconsin. So we received the funding. We were the first of one of two sites to receive funding. Next slide. The name of the program on the grant isn't actually walking forward. It's enhancing Native American participation in radiation trials. I went to Pine Ridge and said that. They asked me if I was crazy or something. So one of our staff came up with the phrase that, we're going to take our time doing this. It's not going to be helicopter research. It's going to take a couple of years to get this off the ground. So the good news, we received a lot of funding. Next day I came into work like, okay, how am I going to do this? Next slide. So this is the high level view for, and I'm going to get into some of these details of 20-year results, the number of grants that we've received. We've recruited about 10%, recruital rate of 10% of American Indians in clinical trials. A lot of this is social science studies. 4,500 American Indians have been enrolled in research studies. We have demonstrated increased compliance with cancer treatment. We've identified specific barriers to effective cancer screening and care. We're now up to about coordinating 4,000 screenings. We completed a genetic study. I'm not going to get into that, but it did show that we're able to do this by establishing trust within the population. We completed a randomized smoking trial. I'll get into a little bit. But a big part of this is just, Monument Health, which used to be Rapid City Regional Hospital, is now a robust research program. And how are you able to implement this level of research in a community setting? There's all sorts of dark tales from the past where people get threatened by change, and that includes hospital administration. That's eventually why we switched from Rapid City to Avera and Sioux Falls. They kind of took us on, all my Avera partners. But Monument Health and Rapid and Sioux Falls get along fine. But it's just something that we had to do 7 years ago, sustainability. So a lot of this has resulted in increased sustainability. And next slide, I want to get into some of the details. So in the navigation, we really wanted to use what's considered the CHR model. That's well known. These are community health workers, but we call ours community research representatives. Everybody that we employ is pretty much Lakota who worked in the trauma communities. They were really our boots on the ground. They're the ones that were promoting education, outreach, networking. We had these really extensive surveys that were done. One was a 1,000 participant survey to determine what some of these barriers were. And these are 1-hour interviews. So this is a really heavy lift and work of social scientists at the University of Wisconsin, Judith Cower and Linda B on this. And then the cancer navigation program. And now navigators are everywhere. Your hotel clerk is now a navigator, right? So the term has been a little bit used too liberally. But their goal was to navigate patients through the complexity of the cancer treatment. I mean, this is all standard of care now, but it's hard enough having cancer. Now imagine in Lakota, you live 3 hours away and you've got to go through all this, you don't have any resources. And so as part of our study design, we actually had funding to help with food, transportation, and lodging to the tune of about $500,000 because it was all part of the study. But their goal in the cancer navigation was to assist them during cancer treatment. No one was coerced to participating in a clinical trial. If they wanted to, they could. If they did, that's fine. Next slide. So what do they do? Cancer education. I mean, some of this is pretty straightforward. This isn't rocket science, but there are people that have been doing this, but there was a big emphasis on cancer education. So Keeley Radio, probably a lot of you are aware of Keeley Radio, in fact, we should log on. But we went down there a lot to get the word out. You know, it's just Tom Casey's interviewed us for years, 20 years. He's coming up here next week. And remember one time, it's probably about a 2 to 2.5 hour drive to go down to Keeley. It's a very beautiful drive. And I'm filling up my truck. It's probably a good gas tank of gas to get down there and back. I was, oh yeah, I heard you on the radio. Yeah, if you get cancer, it doesn't matter. You're going to die anyway. Well, that's not quite true. So that was one of those things that, you know, if you're diagnosed early, there are effective treatment options. I mean, I'm a brachytherapist, so we'll get into that in a little bit. So that was important to the ongoing presence with our staff, just to, again, remind people that it's not a death sentence. So we did a lot of surveys on the trauma communities, patient navigation surveys, networking, but again, they're really the foundation of our program. I would say if we've had any success, it's because of those ladies back there and the other folks in our program. Next slide. So I already mentioned these two. You're both on the slide today. So Romaine and Doris have been with us a long time. There are staff in Pine Ridge. Next slide. From Rosebud, we have Margaret O'Connor, Carolyn Spotted Hill. They all have similar roles, but at times they get funneled into different projects. Next slide. We can't ignore the Rapid City urban population, because there's probably about 8,000 to 10,000 natives live up here. But Chris and Sina and David Coop, of course, with Michelle, our program manager, they coordinate all that. Next slide. So just a brief analysis of some of the data. We did look at Native Americans that were navigated versus those that were not. Now this is the pre-walking forward versus the during the walking forward program, but we were definitely able to demonstrate an increase in compliance, meaning less treatment interruptions through a comprehensive navigation approach. And that's critical for some cancers like head and neck cancer, cervical cancer that we see a lot. You put a week break in the middle of radiation, their cure rates go down by about 7%. And during this time, about 22% of those patients were enrolled on a trial. Next slide. I'll try not to eat the microphone here. Impact of patient navigation, these are cancer patients, reduction in treatment interruptions, overall experience was enhanced. Cultural, they felt our navigators were culturally competent. We did a lot of competency training. Was there a change in trust towards the healthcare system? The answer to that was no. That takes a long time to try to change those mindsets, but those are things we're still working on. Next slide. All right, so first 5 years of grant, my boss at the NCI, his name is Frank Govern. He used to work at Harvard. He was kind of a hard nose, and every 2 to 3 months he would call me and he'd say, okay, how many patients do you have on clinical trials? How many manuscripts have you written? It's like, Frank, we're like in month 8 of this project. I mean, this isn't going to happen overnight. And so even, I didn't show this slide, but it's somewhat amusing, but for every study that we had, including patient navigation, that was an IRB approved protocol, that went through at that time like 7 IRBs through Aberdeen area, the local, the national, Rapid City Regional Hospital, University of Wisconsin, Mayo, and everyone, Dr. Bess is just shaking his head, he understands. A lot of you do too. Every one of those trials included a letter of support. And so each trial is probably like 7 letters of support. So I've got this timeline on the grant that it took 18 months just to get the navigation program going. But the positive side to that is it made us demonstrate to the community that we're in it for the long run. We're not just going to do this and we're out of here in a couple of years. So the NCI wants 2 things. They want manuscripts, they want people on trial. So to do all this, it really starts at the bottom. You need to establish the trust. It helps that I'm a cancer treating physician out here. And so they're going to have an opinion of me one way or the other. If I'm not getting good marks from them, they're probably going to not let me come in the community and work with them. But building that trust up is critical. Cancer screening education, early detection of cancer, There's IH issues with referrals. I mean, we know what the issues are. They're doing their best. They're underfunded. People cycle out every 2 years. There's someone coming in from New Jersey. They're stuck at Pine Ridge, like, oh my God, what am I doing here? So I mean, it's a challenge for the patients, and we get that. But I would say probably the strongest workforce in the trauma communities would be the RNs, the LPNs, the PAs. I mean, they're well established in the community. So I would say with the NCI ones is the frosting on the cake, but we have to have frosting on the cake to continue our funding. All right, next slide. I'll try not to editorialize too much. So clinical trials rationale, that's often how patients do better. It's not experimentation, it's taking treatment A, which we think is the best, and comparing it to treatment B, that's the best, plus something else. Nationally, minority participation rate is very low, especially in our communities, and they thought that was maybe one of the reasons that this led to disparities. Next slide. Now, why weren't people participating in clinical trials? Everybody that was navigated, this was another protocol. We assessed them for their clinical trial eligibility for our own phase 2 trials, as also our clinical trials have to go through the NCI. That's good. So there's a lot of overview. But whether it's an NCI cooperative trial or a walking forward trial, the majority of patients couldn't participate because they were either too sick or they had metastatic disease, and we're not catching the cancers early enough. Next slide. So breast cancer, let's give an example. When I moved here in 1999, I assume a lot of you don't work in the cancer space, and that's fine. But if you take a woman with stage 1 breast cancer, she can either have limited surgery, and at that time, 6 weeks of radiation, or mastectomy. The mastectomy rates in this area in the 90s were over like 95%. So I came out here like, well, that's kind of bizarre because they should only be about 20 to 30%. And that had to do with physician education, patient preference, but it was postulated that maybe one of the reasons that Lakota women are, one of the reasons that not only Lakota women, but just say all the West River patients out here aren't undergoing breast preservation. One could be there are 2 advanced stages of the disease, but 2, it takes 6 weeks of radiation. They're like, I'm not going to live in Rapid City. The same story for the rancher wife, the same thing as the Lakota woman. I can't be away from my community for 6 weeks. So at this time, this is one of our most important phase 2 trials. Next slide. So I'm a brachytherapist. Oh, actually, go to this in a minute. Another thing that we heard from IHS was, well, we don't have the funding if you diagnose all these cancers. Don't throw stones at me, but this is a little bit dark, but maybe it's cheaper when we're not diagnosing cancers. We just kind of let patients be the way that, no one flat out said that, but there was this concern that we're really pushing screening and early detection. Well, we're going to get this flood of cancers. So if women were on patients were on the All Women Count project, which is the breast and cervical cancer screening project, their treatments would be paid for independent of IHS funds. So kind of took care of that issue. So now we have, let's just say we're in Cheyenne River because we had staff there for a while. This woman's on the All Women Count program. Next slide. She's diagnosed with stage 1 breast cancer. That slide looks horrible if you haven't seen this. So rather than doing at that time 6 weeks of radiation, we could put these catheters in the breast. Later, we transitioned into a single entry device in the breast, and they had to have negative margins, negative lymph nodes. But rather than brachytherapy just means radiation delivered at a close distance, rather than having 6 weeks of radiation, they're hooked up to this little robot twice a day for 2 treatments for 5 days, and that's it. And so a lot of women are like, yeah, I'll sign up for that. That wasn't considered a standard of care as part of a clinical trial. So we have a lot of patients, both native and non-native, that roll out a breast brachytherapy trial. Next slide. So 70 patients were put on that study. Their cure rate should be very high. They're stage 1. The toxicities were low. Next slide. Interestingly, and Dr. Best and I talked about this, but Monument Health did not have any navigators during the first part of walking forward. But when they saw how well our navigation program was doing for Lakota patients, they thought, we should really get a breast navigator. And so the hospital back in 2000, I think 2004, 2005, and we were working at the hospital at that time too, they had a comprehensive breast navigation program. We still do. So we wanted to look at the SEER data to see, is there an improvement in breast conservation rates? This is a randomized trial due to the implementation of a dedicated breast navigator and implementing breast brachytherapy. So what you see is that now in 2010 to 2011, the breast preservation rates are now what they should be nationally. So there's an example of a trial that fit the needs of the community. They're very willing to have it done. Next slide.
Oops.
Go back one. No, we just don't pick on women. This is for guys now. Prostate brachytherapy. So a little slide on the left there. Again, this shows up miserably with this background, but so guys with prostate cancer, this is another story in itself. A lot of patients with prostate cancer don't need treatment, but if they meet certain criteria and they want to get treated, they could have surgery, they could have 2 months of daily radiation, they could have prostate brachytherapy. So that on the left is a procedure that we do while patients are asleep, of course. We put anywhere from 60 to 70 seeds into the prostate, and that's it. They're done in an hour, they go home a couple hours later, that's it. So this one wasn't done as part of a clinical trial because it did not need to be done because it was considered a standard of care. But it does kind of cover that spectrum of early stages of cancer. You're a candidate for this. You can come in and get this done, go home within a couple hours, and that was a very effective way of treatment. The one on the right is for patients with more advanced stages of cancer. It's called high dose rate brachytherapy. We do this for cervical cancer as well. But that's another, we had a phase 2 clinical trial combining daily radiation and brachytherapy, and the cure rates are higher if you do both compared to daily radiation. And again, these are all kind of separate topics in themselves, but I'm trying to give you a high level overview. Next slide. So, total therapy. I trained at the University of Wisconsin. In 2000, probably 2001, 2002, a guy named Rock Mackey was a game changer in the world of radiation oncology. So this machine called tomotherapy, the formal name is intensity modulated radiation therapy. What in the world is that? It just means that we could deliver it with a higher degree of accuracy. So at that time, the hospital was agreeable to being the 4th site in the world to get this. And the idea is, not the idea of how it works is, rather than giving radiation from stationary angles, it treats helically. And so it gives us the ability to, one, treat the tumor to a higher dose, and number 2, to spare more normal tissues. So when this was implemented, this is Carolyn Spotted-Tail and her family. We had a medicine man who came in and blessed the machine. Next slide. But one of the most rapidly occurring trials that we had was, rather than doing 38 daily radiation treatments, as part of a clinical trial with 5 other universities, we were a community site, is reducing the number of treatments from initially from 38 to 12, from 22 to 16 to 12 by giving a little higher dose. Next slide. That was another clinical trial that both the natives and non-natives found very agreeable to participate in because it saved them time. This just shows the cure rates are very high. Next slide. All right, so then we get into phase 2 of walking forward. We received another cycle of funding. But what we wanted to do, is one of the data points that came out of our survey is that if an IHS provider, I'll try to finish in 15 minutes or 10 minutes, recommended a cancer screening test, it was much more likely that they were going to get that test done. So now in this second phase of walking forward, we have our community navigation program, our cancer navigation program, but then we embedded a cancer screening coordinator within each IHS hospital. That actually took a congressional letter to get that done, but it just sometimes how it works. Next slide. So this is just an example. This is one of our staff in Cheyenne River doing a cancer screening event. If patients wanted to, as part of a protocol, they could sign up for a screening. We were allowed to follow them until either they had a normal test, or if they had an abnormal test, we could refer them. There was an effort to shorten the time to duration for, instead of having symptoms for 6 months, it takes 6 months to see a doctor, and it takes 6 months to get a diagnosis, and it takes another 6 months to get your cancer treatment. At that point, probably stage 4. So that was that big effort that we did during the second phase. Next slide. People outside this area don't realize how remote these communities are. This is Rosemont. We did one of our community events where there's no internet service, there's no cell phone service. So our staff recruits patients to remote locations, oftentimes walking on doors. Next slide. So this was, as of now, I'd say we've probably coordinated over 4,000 screenings for screen detectable cancers. Next slide. We can't read any of this. We did look at the data about 10 years ago at looking at pre-walking forward versus walking forward era. And there's at least a suggestion that patients are presenting with earlier stages of cancer. Next slide. All right. 2011, the NCI closes down the CDRP program. They say you're going to graduate, which is a euphemism for go find your own money. That's great. So we put together another project. We kept doing navigation. And so this project was done with Mark Dignan, Linda Burhan-Stefanoff, Linda Krebs. Next slide. So this was a randomized controlled trial looking at 4 interventions: nicotine replacement, counseling, smartphones. They're actually dumb phones, but they could send text messages. But this was 256 patients that participated in this randomized trial. Next slide. Again, this is another talk in itself. The quit rate at 1 year was about 21%. The longer people, the study was exclusively for Dakota, the longer you stayed in the study, the higher the odds that you would remain smoke-free. Next slide. All right. Then I asked them while we were in Sioux Falls at the Petereit in 2016, well, what do you want to do next? Was that grant ran out? Again, we're still doing navigation. And I knew what I kind of wanted to do. So we thought, really the biggest issue that we see out here is lung cancer. That causes the most deaths, not only in the US, but especially in the Northern Plains. Next slide. So what are the high level points here? This has been published. Northern Plains have Indians, Native Americans have the highest lung cancer death rate. This is data from our own cancer center. It parallels that. There's high smoking rates. Next slide. This was back in 2007, but at that time, I would say, about 0% of the Dakota people were screened. We calculated about 30,000 people at risk for lung cancer in South Dakota, with at least 14,000 in our part of the state. There was really limited utilization of LDCTs. We saw what's that? That's a low dose CT scan. It's a 1-minute scan. There's no IV contrast. We know the data that works much better than chest X-rays. Many high-risk individuals aren't aware. But if you're going to screen for cancer, can you do anything about it? The answer is yes. They can have surgery with high rates of cure. A lot of these patients have bad lungs, but they could have what's called stereotactic radiation with 3 to 4 or 5 treatments every other day. Cure rates are 90 to 95% with really no side effects. Next slide. So the research question was, will provider and/or individual level interventions increase rates of LDCT utilizations for high-risk smokers in Western South Dakota? Again, this is the first project that we did for both natives and non-natives. And the primary goal or metric was to increase rates of LDCT utilization. Next slide. So Western South Dakota, guess what? There's not many LDCT sites. In fact, they're not offered at any of the reservations. Rosebud is going to start offering them pretty soon, but the only areas of West River, Black Hills does a lot, would be Phillip and Pierre. Next slide. So the intervention that we did is a 2x2 study looking at provider intervention, meaning CME talks versus individual interventions. Go ahead to the next slide, kind of wrap up here in a little bit. My Venn diagram doesn't show up at all. Should look my blue slides. So we got the provider CME education, we've got the community education workshop, and then we had surveys at our imaging centers. Next slide. So our staff was great about, we had, I don't say contracts, with agreements with every imaging center. I've been here since 1999. So anyone I need to get a hold of, I had their cell phone number. So I can track people down, I can hassle them. And I'm like, God, it's Petereit, I know Z1. But they've been good award winnings. So with these provider workshops, they've completed them 135. They've done 1,000 community workshops. And to date, we've had 338 LDCT referrals, 270 completed, and almost 40% American Indian. The screening rate before this for American Indians was about 0% unless you went to the VA. Next slide. All right, so which intervention will work best? We're analyzing that right now. Hopefully have that data in a little bit. So we're putting another grant with Dieter Buchwald in about 2 months. So what are some of the, well, IJust does not provide LDCTs. So when I went down to OSTIRB, they said, well, that's great, Dr. Petereit, you're going to educate our population, but we don't offer. I said, don't worry about it, we're working on it. So like manna falling out of the sky, this is with, with what Avera has access to. This group came to us, the Irving A. Hansen Memorial Foundation. They gave us $152,000 to screen patients without insurance. So then we worked with our radiologist, charged $250 for everything, which isn't bad. And so the process to get patients screened, and Margaret will tell you, Romaine will tell you back there, this is the importance of patient navigation. After she's done her workshop, we can get those patients screened. We have a stipend for travel and other stipends if they need it. And so this additional grant money allows us to will allow us to screen 400 Lakota patients And we just received another 85,000 to extend the project another year. One of the concerns is Dr. Best and everybody else knows that works in the space is this is soft money. This is great. You guys set up this program, now you're going to your next program. So we are going to continue this. Next slide. I'll wrap up here in a bit. Love this slide. This is from Romaine. She can tell you the story, but this is Romaine getting consent for the 6-month survey on the hood of her truck after a blizzard in western South Dakota in the valley where the Wounded Knee massacre happened, and this couple had to walk up this gravel road. I mean, you show these slides to people across the nation that just have no idea what it takes. So, Romaine, I love that story. Next slide. We did a healthcare symposium last fall. I think some of you were there. So we want to affect policy. IHS should be covering the costs of LDCTs, period. So we are working with them, and I bug the radiologist down there, and they remind me how important it is. I said, I know, get it going. Next slide. So we're going to continue that. I'm going to skip this, but they have changed the screening recommendations for lung cancer. All right, so go back one more. So right now we're in phase 5. This all overlaps. This is a palliative care grant that we have. Next slide. So this is the name of this grant is Advancing Palliative Care in the Northern Plains American Indians. Someone's got to teach me Lakota sometime, but there's really no word for Lakota for palliation in the native language. And so when our cabs came up with this living well with serious illness, and so that's the Lakota phrase for that. And so the partners on this are Katrina Armstrong. If you know the Boston folks in Rosebud, that's her program. She, Walking Forward to Bear, are partners on this, in addition to SDSU, Great Plains Tribal Children's Health Board, the 3 reservations. The overarching project goal is to develop and test a multi-pronged strategy for delivery of palliative care for Northern Plains American Indians. All phases of this project have been guided by our CAB. Next slide. So we are done with phase 1. Why is this an issue? I'll back up here for a second. I mean, this happens all the time. I mean, I have a patient from Pine Ridge, Rosebud, Cheyenne River. Okay, they've gone through their cancer treatment. Unfortunately, they're progressing. They're not going to be cured. They go home. What's available for them? I mean, there is some services available, but there's no hospice house. There is progress being made. All right, next slide. So we've completed phase 1, which is interviewing 35 people, 30 medical providers about living well with cancer. We've identified themes, there's manuscripts on this, but what are we going to do with it? So right now we're into phase 2. So phase 2, next slide, and you can't read this either, but this is basically what this looks like is the navigation model for delivering palliative care. I mean, Romaine, Doris, and our other workers, they're not hospice workers, but we've got a program in place to start addressing these needs. And that's another topic. Next question. Or question, how about the next slide? Now we just put another RO1 in. This is Dr. Tilbert at Mayo. Usually you guys get ignored out there. If you do focus groups out there, 95% of women kind of ignore the guys, probably because guys don't want to talk about their health. So we just put in this grant a couple of days ago. This is a men's healthcare initiative. Next slide. This is our staff. 3 of our staff are here. Next slide. I'm almost done. These have been 3 of our key collaborators, Norm Coleman from the NCI, Linda B, and Ashley Ballard, and all those enrolled member of one of the Oklahoma tribes. She's a radiation oncologist down in MD Anderson, but she's been a key collaborator. Next slide. So our vision is to improve the quality of life for American Indian cancer patients from early detection, successful treatment, and survivorship, including end-of-life care. Our mission is, this has been and will continue to be accomplished through access to screening, state-of-the-art cancer treatments, and clinical trials, and comprehensive patient navigation. Next slide. So we're in that phase right now where we keep living on R1s, and that's fine. And you can ask our staff this. We kind of ask them to be researchers and navigators. We eventually see Walking Forward kind of being divided up into one is surface for patients, which we always have done, as well as the research. That's when we start asking foundations if they're interested in supporting continuation of the project. We're good for another 5 years, but that's what things are going to look like. Next slide. All right, I'll end there. Happy to take a few questions. Sorry, I went over by a couple minutes.
No problem. Okay.
You're all asleep. I'm trying to get out of here.
Let's give Dr. Petereit a thank you. Questions from our audience today for Dr. Petereit? Well, best.
Thank you. I've never seen anyone go through so many slides so effectively.
And that's half of what I usually do, so.
My question is, for over 20 years now, you've been working with 1 foot in clinical care and 1 foot in research. And I think it's a model that is very, very useful. It's somewhat what I've done as well up in Turtle Mountain. But what I'd like to see is if there are any suggestions on how to get more clinicians interested in this paradigm. Is there any way to do that? I've failed.
I worry about that too, because I'll be hitting 60 in a couple months, and I probably need to start slowing down at 65 because I'm just running 100 miles an hour. So my thoughts on that are, the unfortunate reality is most physicians and community practices aren't going to do this. They're like, don't have the bandwidth, don't have the interest, they don't want to deal with it. Okay, but I think there are other people that are coming out of training that are interested in doing this. And it's interesting that people out of radiation oncology programs, there's a lot of residents that have been rotating with me to figure out how to do this. I mean, if it wasn't for this NCI grant, I would have never, I would have kept doing what I'd like to do, but this would have never been pulled. Don Warren with his, Dr. Warren with this program at UND, I think, I've talked to him, if he has junior investigators, if we could bring somebody on out here to work with me. I mean, they're probably smarter than I am because they've got MPHs and PhDs. But I mean, I got my MPH at the School of Hard Knocks, but I didn't go through this formal training. But I think it's an awareness, but I agree, it's a frustration of mine too, because there's not anyone in Rapid City I know that wants to take over. So I think it would be, residents coming out of training, possibly Dr. Warren's program. He does a terrific job up there. But yeah, I'm sure you felt like you've been kind of an island yourself trying to do this, and your colleagues are looking at you, why are you doing this? So I'm working on it. It's a great question. I have ideas, but so far I haven't been able to quite figure it out yet. Happy to share any of our information. I'll give you my cell phone, email. If it's really just, I tell people, if you want me to read your email, just put urgent read, because I get so many emails, and just at the end of the day, I just kind of like brain dead. So, but very happy to visit with you in the partnership with Avera that we've gone with. And in Monument and Avera, it's been a nice working relationship. But I would say one of the main reasons that we transitioned over is they don't have the research infrastructure that Avera has. So it's very important to have that. I would say the protective floor, when you're out of cycles of grant funding, they carried us for about a year when we were between cycles of funding. We can keep talking further, but I'm sure you want to take a little break. All right, thanks for your time.